Good afternoon, everyone. I welcome you to today's CPC, which is for the Department of Pediatric Surgery. Our discussant today is Dr. Mahajan, who is the Professor and Head of Department of Pediatric Surgery at the Advanced Pediatric Center, PGI Chandigarh. Sir completed his MBBS from IGMC Shimla, followed by his MS at IGMC Shimla as well, and then he did his MCH Pediatric Surgery from PGI Chandigarh. Post MCH, he has 27 years of experience in the field. His areas of interest include pediatric urology and neonatal surgery, and he's the lead faculty for Pediatric Urology Fellowship at PGI Chandigarh. Professor Mahajan has more than 125 publications in reputed journals and several book chapters to his credit, and he's the recipient of several best paper awards, including the prestigious UC Chakraborty Award by the Indian Association of Pediatric Surgeons. He has guided nearly 30 MCH and postgraduate students till date, and I am certain that our residents here will learn a lot from his approach to the case today. We welcome you, sir.
Thank you. Good afternoon, everybody. I'm grateful for the invitation to present this CPC today. So I will start with the clinical protocol. So this is a 5-year-old female patient who presented to Pediatric Surgery Department of All India Institute of Medical Sciences for evaluation of renal mass. Patient was apparently well, other than pain abdomen for 6 months, which was intermittent and progressive in nature with no specific aggravating or relieving factors. Bladder and bowel habits were normal, and other relevant history like weight loss, hematuria, jaundice, vomiting, hematemesis, urinary or bowel complaints, dyspnea, hemoptysis were absent. There was no history of abnormal body movements or eye movements, and no history of having received chemotherapy. Past medical history, surgical history, and birth history were unremarkable, and no family history of tumors in the family or in siblings was there. Child had development history was normal and had immunization, complete immunization till date. General physical examination, child was apparently alert, active, with no other general physical signs of any significance, and hemodynamically the child was stable with no skin discolorations. Eye examination, especially aniridia, which one has to look for renal patient with renal tumors, were normal. Genitalia were normal. Systemic examination for respiratory, cardiovascular, and central nervous system was also within normal limits. On abdominal examination, there was a 4 into 4 centimeter lump palpable in right lumbar region with well-defined margin, except on the upper part where the lump was disappearing under the right rib cage with smooth surface and firm consistency. Mass was velatable. It did not move with the respiration, and there were no changes in the skin over the mass. Investigations in form of complete blood count, renal function tests, and electrolytes were within normal limits. Then when such patients come, imaging investigation which are done are in form of ultrasound and CT scan. So contrast enhanced CT scan. So both these investigations were done for this patient. Ultrasound showed that organ of origin is kidney, and there was a large size lump with sharp margins and echogenic heterogeneity, indicating of renal tumor. And I'll come to the differential diagnosis, what renal tumor of such in such a age can be there. Contrast enhanced CT scan was also done for this patient. The pictures are slightly hazy, but when we start looking at serial sections, one can see that kidney has started to appear here. Here also the kidney is appearing. Here there is some evidence of mass, but as you go down, the mass start appearing. So further pictures, here you can see that kidney is enhancing, which is more than mass, but there is enhancement of mass as well. And peripheral rim of kidney tissue can be seen here. As you go down further in serial sections, the mass becomes more prominent. So this picture is a better one. So here the kidney tissue can be seen on one side and enhancing mass seen on the other side. Inferior vena cava appears to be free and the other kidney is normal. There is no evidence of any tumor in the other kidney. So in this picture, the pelvic glacial system is shifted to one side and the mass can be seen, and these section also, the kidney tissue on one side and one can see mass. So from this picture, like one can say that it is a well-defined heterogeneous enhancing mass in lower half of kidney displacing renal parenchyma to one side. There was no evidence of IVC involvement. Mass appeared to be within kidney and left kidney and other organs were normal. In a patient of renal tumor, one has to do imaging of lungs also to rule out any metastasis. So CECT chest was done, which did not show any evidence of metastasis. So if we summarize this patient for the sake of diagnosis, 5-year-old female child with pain abdomen, a 4 into 4 centimeter smooth, well-defined, firm, non-palatable lump in right lumbar region, ultrasound showing echogenic mass as compared to normal kidney, and CECT showed heterogeneous, well-defined lump of kidney origin appearing towards later cuts in the serial sections, indicating involvement of lower part of kidney. IVC appeared to be free. A thin rim of kidney tissue seen around the mass. Lymph nodes around aortic area were not enlarged. So with this picture in mind, this is a list of renal masses, renal tumors seen in children, not essentially the differential diagnosis. This is a whole list of renal tumors which are commonly seen, but not all of these renal tumors will occur in a 5-year-old child. So in a 5-year-old, what are the possibilities? One by one, we will rule out these common tumors and see whether possibility, which of these is likely to be present. So diagnostic possibility, which by ruling out conditions one by one, Wilms tumor is the most common renal tumor seen in children. Almost 80-85% of tumors are Wilms tumor. So in our patient also fits into age group, the clinical presentation and imaging pictures into the Wilms tumor. So that remains the first possibility. CT and MRI will show enhancement of tumor, which is lesser than the parenchyma that was seen in this patient, and normal renal tissue displaced by the tumor was also seen. Then these are like other things which you see on CT scan which were not seen in our patient. Another possibility is clear cell sarcoma, but clear cell sarcoma imaging pictures, it is difficult to differentiate from Wilms tumor. But other features which were not matching or not in favor of it being clear cell sarcoma, male preponderance, bone, it is a bone metastasizing tumor, and increased number of brain metastases are seen. So in our patient, there was no indications of any bone metastasis or any evidence of brain metastasis. Then next tumor, which is although uncommon but seen more commonly than other tumors, is a renal cell carcinoma. Renal cell carcinoma also, the imaging pictures will be similar. Patient will present without any great evidence of symptoms, but features against it being renal cell carcinoma, that it's rare in first 2 decades of life. Mean age of presentation is around 9 years, and only differentiating features Wilms tumor and renal cell carcinoma is that renal cell carcinoma presents in a older age. Then ring-like calcification are unusual for Wilms tumor, may be seen in renal cell carcinoma. So in our patient, there were no calcification seen. Another tumor is rhabdoid tumor of kidney. It is one of the most malignant tumors of kidney, but differentiating feature again, it presents in younger age. First year of life, infants and young children, it is the common presentation. So this is also not the possibility. So presence of hypercalcemia, diffuse lymphatic and hematogenous spread in a young infant, that is feature of rhabdoid tumor. So doesn't match with our features of our patient. Then congenital mesoblastic nephroma, again it's a renal tumor of infancy, so ruled out. CT will show heterogeneous solid mass arising from kidney. Picture may be similar to the one which we saw, but clinical picture doesn't match, so ruled out. Then another commonly seen tumor is multilocular cystic nephroma. The picture is like a cystic tumor, which was not present in this patient, but it is seen around children younger than 4 years, so commonly 24 months, so male predominance. So that in a way rules out again, this is not the possibility. So cystic partially differentiated nephroblastoma, again tumor seen around first year of age. Then rarely lymphomas and leukemias may present as tumors, but generally bilateral, and diffuse infiltration is there. So not again not seen in our matching with our patient. Then some benign tumors. I talked about malignant and benign tumors, but there are some benign tumors which are in others category, like angiomyolipomas. Angiomyolipomas, fat infiltration will be there. So imaging pictures will show macroscopic fat, which was not seen in our patient. Then similarly, pseudotumor, clinical picture did not match with pseudotumors. Then another is metanephric adenomas. Metanephric adenoma are tumors composed of epithelial and stromal cells. Radiological picture is similar to renal cell carcinoma and Wilms tumor, making preoperative diagnosis difficult. So if such a situation is there, Wilms tumor remains the first possibility. But occasionally this may be there. These are actually incidences not very high. So just one can keep these rare tumors in mind. Then metanephric stromal tumor, presentation around 2 years, does not match. Then to complete the list, ossifying renal tumor of infancy and reninoma. So there was a nice paper from American Academy of Pediatrics who reviewed the tumors, renal tumors, and given a comprehensive list. So this list is from that paper. So as one can see that differential diagnosis of tumors of renal origin in pediatric patients is a function of age. So our patient fell into unilateral tumor, fell into category of 2 to 6 years. So Wilms tumor remains the first possibility. Clear cell sarcoma not fitting into the picture because of absence of bone metastasis and indications of cerebral or brain metastasis. Multilocular cystic nephroma, because the radiological picture was not matching, and metanephric adenoma can be a rare possibility, occasional one may come across. So these are the three things which, according to the clinical and radiological picture, our patient will probably fit into this. So, should I go ahead and talk about treatment also? So, then once renal tumor is there, so what is the treatment? What are the issues with treatment? What kind of treatment is required? In a non-syndromic, which this patient was, non-syndromic unilateral renal tumor, possibly Wilms, radical nephroureterectomy with lymph node sampling is standard of care. Goals to remove kidney without intraoperative spill, sample lymph nodes, and document all the findings like pre or intraoperative rupture, extension into other structures, and presence of peritoneal metastasis, because that has got implications for post-operative treatment, which we are planning to do. So when to do that nephrectomy, there are two main groups who are doing trials on treatment of Wilms tumor, Children Oncology Group and International Society of Pediatric Oncology, mainly active in European countries. So they differ in timing of surgery. Upfront surgery is the philosophy of Children Oncology Group, and whereas COP will do surgery after first-line chemotherapy has been exhausted. There have been long-term concerns about the effects of radical nephrectomy. That radical nephrectomy may lead to significant chronic kidney disease and hypertension in patients who are left with single kidney in the long run. In a study of 25,000 childhood cancer survivals, 35 years cumulative incidence of late onset kidney disease was found to be present in about 1.7%. So then some people started propagating that if there is a possibility of organ sparing approach following the proper oncological principles, that can be exercised. There is a long list of preconditions for kidney preserving surgical approach in Wilms tumor, and these preconditions have to be fulfilled before one can take up kidney preserving or nephron sparing surgery is also, it is called, for unilateral renal tumors. So when one goes through these conditions, only 3 to 9% of non-syndromic patients, they fit into nephron sparing surgery based on the studies by both the groups, COP as well as COG groups. COP protocol has defined very strict indications for nephron sparing surgery for unilateral Wilms tumor. Nephron sparing surgery is used for bilateral Wilms tumor, syndromic patients, but unilateral Wilms tumor, that tumor has to be restricted to one pole of kidney. Estimated volume should be less than 300 ml at diagnosis. No preoperative rupture, no obvious venous or local extension, and enough remnant of kidney is left behind to prevent hyperfiltration injury. So one has to weigh the risk of under treatment by doing nephron sparing surgery, increasing the risk of local recurrence versus possible benefits of decreasing the incidence of renal failure in the long run. So to remember that only 3 to 9% of patients are suitable for this kind of treatment. Another minimal invasive approach for Wilms tumor has been laparoscopic tumor nephrectomy if certain criteria are fulfilled. That oncological principle should not be violated. For small and tumors, MIS is appropriate. Extraction of specimen has to be without causing tumor spill, and if feasible, nephron sparing is preferred over MIS. So there are obvious contraindications for minimal invasive, that if it is going beyond the capsule, spread is there, lymph nodes are involved, then MIS is not suitable. So this patient underwent upfront surgical resection with right nephron sparing surgery, in the sense that right partial nephrectomy was done and postoperative period was uneventful, and patient as of now is doing well. So that finishes.
Thank you, sir. So, would you have also chosen to do a nephron sparing surgery for this patient?
As I said, that standard of treatment for unilateral non-syndromic Wilms tumor is radical nephrectomy. So, although nephron sparing is coming up, but personally I would have chosen radical nephrectomy. So, because if you see that percentage of patients suitable for nephron sparing, only 3 to 9%, and the long-term renal failure, long-term renal function, like I presented one study in which it is around 1.7%, but generally there are other studies also who would say that it's around less than 1%, 0.5%, 0.25%. So it's a matter of personal preference and choice. At the same time, for doing nephron sparing, there are few other things which should be available. Like if you are planning to do intraoperative frozen section is one of them. So if intraoperative frozen section is available, then you choose to do nephron sparing, and with the possibility of converting nephron sparing to radical nephrectomy. So it's upcoming area. As of now, like I'm maybe old school, but I would have done radical nephrectomy.
Thank you, sir, for your excellent discussion. I now invite comment from the clinical team. Dr. Devender, would you like to tell us about what was your clinical diagnosis?
Thank you, Dr. Aanchal. Initially, the patient was presented with a renal lump, and the lump was totally free from the abdominal structure and mobile. We worked up the patient in the line of Wilms tumor, but in our department we are not trying to do some randomized study in form of partial nephrectomy for few Wilms tumor in few selected cases. That's why I planned an initial renal dynamic scan in this patient, but ultimately I go with the mind that I will remove the whole of the kidney. But when we reach in the around the tumor's site, it's very difficult to find any lymph node. There was not even a single lymph node was enlarged, and tumors was looking not like a Wilms tumor. So again, I think what should I do? But then I assess whether this tumor is approaching to the pelvis or not. So this tumor was slightly away from the pelvis, and we can easily spare the renal vessels. That's why we plan that there is no lymph node. I was not able to sample a single of lymph node. Though it's not always said, even if you are not able to sample a single lymph node, just go to the area suprahilar part, infrahilar part, and take tissue from that area. You may find some small lymph node, but I think there is no lymph node, so I will go for the partial nephrectomy with a clear-cut margin. But again, as sir explained, all the literature pertaining to the partial nephrectomy, but I think the partial nephrectomy, especially, we are not aware, especially in cases of polar tumor, what is the condition of biochemical marker in the normal kidney. Because one of our project is with Sandeep sir and Venkat sir also there. When we are planning, we are doing the with the help of MLPA 1Q and 11 or 1Q gain. So in the normal kidney, which is not involved by the tumor, there is this specimen also showing the expression of some these genetic changes. So that's why whenever we should plan a partial nephrectomy, this should be based on a definite protocol as explained as denoted by SIO study. So in view of that, I go for the partial nephrectomy.
So as Dr. Devendra mentioned, it did not look like a Wilms tumor intraoperatively. Does the audience have any alternative diagnosis?
I think when we go and we want to consumer, as I think I don't remember the other things, we have two options. Either you go and we get data, or we do a biopsy. And sometimes storing is not very good for this thing. The biopsy and come out, and you can always go back and be normal cases of lymphoma. So that is another good option. It didn't look like angiogram. So that is another option. Yes. But I think knowing very well that if the lymph are positive.
Thank you, sir. Dr. Manisha, would you like to add anything to the imaging?
Good answer. Actually, the renal mass imaging, so person is solid or it is cystic or it's mixed. So here on ultrasound CT, both ways it was like solid. So once we see a solid mass at this stage, we really have like 2 or 3 body possibilities. So it's human and RCC if it's the motor side or cases are because we will be like any other than a solid renal mass. Yes, in cases of benign tumors versus Wilms tumor, diffusion weighted imaging would have added something to say if we are thinking about something benign, then it would have shown a less restriction. And because it was looking like solid mass only, but diffusion definitely would have added it.
Currently, I think most of the European groups are now promoting MRI for all the those chest or chest because MRI tends to give a lot of more information. As the such as benign, we do a repeated MRI, and also it's a better looking without photographs. Is there any difference on MRI?
Sir, renal cell carcinoma and Wilms tumor, exactly on CT there is no differentiating word other than that we get the AIDS, mainly the AIDS group, and thrombus can happen in both, continuous thrombus lymphadenopathy. This calcification we can see in cases of RCC, but Wilms tumor it's pretty rare. That again, there is some overlap between these two, so clearly we cannot differentiate. Even in MRI, even also, we are not really sure whether it is RCC versus Wilms tumor. Dr. Deva, any thought?
There was less diffusion restriction or something. Our differentials would have been the same. Maybe there would have been some doubt regarding the diagnosis, but solid tumor in this age group, from imaging point of view, we cannot go beyond this.
Multiphasic CT, and that way in adult renal tumors they are more established. Not in pediatric renal tumors, the contrast dynamic characteristic is not that well applicable.
Yes.
Sir, one point, how we differ from the COP of the side of the in most of the cases we go pretty or very few
So in scientific itself is not center you do linear biopsies, also human biopsy. You are medical pathologists.
No, actually, we have very good pediatric neuro-oncology department. They are doing all chemotherapy and in fact all because with them first. So invariably they will based on clinical and radiological picture they will start chemotherapy. Rarely if the picture is not matching with the diagnosis or like an immune tumor if there is doubt, then occasionally they will do final respiration pathology or sometimes do biopsy. Otherwise, most of the time it is based on clinical and radiological.
So even the major international protocols, like the European protocol, is not suggesting any histological diagnosis. Dr. Kakkar, you have a vast experience on FNAC for renal tumors.
most of the centers have stopped doing this. So the last 20 years there have been debate. People have been doing FNAC, we have been doing a lot of FNAC. PGIMER was doing a lot of FNAC. But slowly now the trend has come down. And even those who advocated biopsies in pediatric renal tumors maybe 5-6 years ago, the trend is come down. So there is now, I don't know if answers will present that. When to do a biopsy or an FNAC, there is a chart now. There is a if you are getting the age and their criteria are there, then only if you do it for a routine one like this, one may not have it after the surgery.
I'm not showing the list of indications for an FNAC, but I think that if there are atypical features on radiology and if the age is unusual, that is when
Less than 6 months and more than 6 years. So
Right.
the protocols mentioned and if it is now the European protocol is 7 years.
So less than 6 months and more than 7 years to do a biopsy. But let me add that the European protocol had about 7% misdiagnosis. I mean, not any of which was tumor, but most of them were still malignant tumors, cases sarcoma and blood. Only 1% were benign tumors, and for which unnecessary chemotherapy, because they are giving upfront chemotherapy, was given to them. So now there is another reason for doing biopsy. They have gone back to doing biopsies. The European protocol is suggesting that you do a biopsy because now they want a tissue upfront for molecular diagnosis. So that is the only reason for doing the biopsy. So doing a biopsy otherwise is not. If you are not doing molecular study, then there is no need for doing it. But if you want tissue for molecular studies, then the same thing is about liver tumor. You do a biopsy for molecular and genetic studies. So we don't know how good are the molecular and genetic studies after having the chemotherapy. That is important. So one Q, LOH, everything is before the chemotherapy. So that is the reason why.
Thank you, sir. So let's move on with what we saw in this case. So this is the requisition form, and the information for the pathology residents that you want to take back is what is the age of the patient, because as sir mentioned, the age of the patient is going to help you narrow down your differential diagnosis up front. And what is the surgical procedure performed? This was mentioned as nephrouretrectomy, but when we saw the gross specimen, clearly it wasn't, and we clarified that later. And this came to us saying Wilms tumor, and this is the gross specimen. You can see that this is the external aspect. You can see this is the normal renal cortex, the pelvic system, and here you have a tumor. This is the cut surface of the tumor, and all of you, the residents, would agree that this does not look like a Wilms tumor. It appears quite reddish and fleshy with some septations dividing it into large lobules. What a Wilms tumor looks like is this. This is one of our recent cases. That is what a Wilms tumor looks like with a fish flesh appearance. So clearly it is very different from what a Wilms tumor would look like. Let's go to the microscopy. What we have here is, this is the renal. So this here is the renal capsule. and just beneath that we have a lesion which is composed of multiple cystic spaces. It is not solid as it appeared on imaging. Multiple cystic spaces, all of which are filled with pink fluidy material as well as red blood cells at places. You can see here that it is close. This is the renal pyramid. This is the lining of the pelvic calyceal system, and it is close to the one of the calyces. And at the periphery, you can see that there is some lymphocytic infiltrate, and this is the lesion here. So you can see that there are variably sized cystic spaces which are lined by very flattened, kind of very thin walls. And here you can see that there are some larger vascular structures which have smooth muscle in their wall, but they don't have an internal elastic lamina. So these are probably draining veins or feeder vessels, similar ones seen here, whereas the rest of these are just lined by flattened cells. In other areas, we had smaller cysts almost becoming solid at places, but these again are also made up of very small cystic spaces which are lined by similar cells. So here you can see on high magnification that these cells have virtually no cytoplasm and very monotonous appearing nuclei without any pleomorphism, and it's just a single layer of cells that is lining these septae. And you can see similar features in the more solid appearing areas. Obviously it is more cellular, but there are lumina in all these areas as well. So to summarize, we have a tumor, which is a lesion which is compared of variably sized thin walled spaces lined by flat cells with scant cytoplasm which lack nuclear pleomorphism. These spaces contain eosinophilic material and scant RBCs and lymphocytes are present. So what is the differential diagnosis here? So my first differential diagnosis was a lymphangioma, and it's something that we haven't seen in the kidney before. So I asked one of my senior colleagues and he said, Aanchal, this is thyroid follicular like RCC, because those spaces filled with eosinophilic material resembles colloid, which is seen in thyroid. This is in thyroid follicles, and this is a recently described subtype of renal cell carcinoma, quite rare again. And when you're looking at a pediatric kidney, you want to make sure that you're not missing out on the more common cystic tumors. So you would want to essentially rule out a cystic nephroma or a cystic Wilms tumor. So let's go to the more common lesions first, looking at cystic nephroma. This is a benign multilocular cystic neoplasm which has now been found to be associated with Dicer-1 syndrome. Most patients are under 2 years of age and they present with a palpable abdominal mass. 25% of cases can be bilateral. These are usually large tumors with a mean diameter of about 10 centimeters and they are well circumscribed. They consist entirely of variably sized cysts which do not have expansive solid nodules by definition. On histopathology, you can see here that there are multiple cystic spaces and which have thin septae, and the septae show fibrous tissue or fibroblastic cells. You don't get any blastemal component at all within these septae. And they might be lined by flattened or cuboidal or hobnailed epithelium, which is positive for cytokeratin because it's epithelial, and PAX8, which is a nuclear transcription factor that plays a role in the development of the kidney. And Dicer-1 mutation is seen in 90% of these cases, and these have an extremely good outcome following partial or complete nephrectomy. So we didn't see any kind of fibroblastic cells within the septae in our tumor, so this one seems unlikely. Next we come to cystic Wilms tumor. We all know Wilms tumor is a malignant embryonal neoplasm which replicates the histology of developing kidneys and has divergent patterns of differentiation. The mean age of diagnosis is 3 years in males, 4 years in females, so it's pretty good for this patient. But on histology, we know that it shows a typical triphasic appearance with blastema, epithelial and stromal components. You can have a cystic Wilms tumor, but it will show unequivocal solid nodules with typical histology. For example, this is one of our recent cases, but this was post-chemotherapy. So cystic Wilms tumor is more frequent post-chemotherapy rather than upfront. So you can see there are a number of cystic spaces, but when you look at other areas, it is solid, and these nodules of small round blue cells giving this blue appearance are present. That's the blastemal component, so it will always be present. Just to cover the immunohistochemistry of Wilms tumor, WT1 is the most specific and sensitive marker, positive in 90% of cases. It stains the blastema diffusely, which also stains for Pax8. The epithelial component would be positive for cytokeratin and show variable Pax8 and WT1, whereas the stroma shows weak WT1 positivity and shows non-specific staining for Vimentin, BCL2, CD34. So we did not have these solid nodules at all, so we excluded cystic films upfront. Coming to thyroid follicle-like RCC, it's a subtype that microscopically resembles thyroid follicular neoplasms. You can see these cystic spaces which are filled with eosinophilic material, but it is thick eosinophilic material like colloid rather than pale eosinophilic material which we saw in our case. These are well circumscribed encapsulated tumors. They're very rare, about 40 cases have been reported, but it has been described in children as well. So here you see tightly packed cysts with this colloid-like content, and they're lined by columnar or cuboidal cells with abundant eosinophilic cytoplasm and uniform nuclei. At least focal nuclear overlapping is present, palisading of tumor cells, and the nuclear grade is grade 2 or 3. That means that nucleoli are appreciable either at 40x magnification or 10x magnification. Our case did not show the presence of nucleoli. On immunohistochemistry, again it stains with cytokeratin and Pax8 and shows patchy Amaker staining, but is negative for WT1 and thyroid markers, of course. And it has an indolent clinical course. However, in 6 of those 40 cases, metastases have been described. So we didn't have these nuclear features, making it unlikely, but we want to consider it because it has been described in children. There are case reports, especially following patients who had hematopoietic malignancies. Lastly, we come to renal lymphangioma, when the preferred term is lymphatic malformation now. These are benign lesions thought to originate from the dilated lymphatic channels or developmental malformations of the lymphatic system. We know cystic hygromas is the most common and they frequently occur in the neck and axilla. Rarely these may be seen in the mesentery, retroperitoneum, abdominal viscera and mediastinum. Less than 50 cases have been reported in the kidney, ranging in age from newborn to 79 years. And they can present with hypertension, ascites, renal insufficiency. These are one of the cases that has been reported in literature, but on cross you can see that it does show the presence of large cystic spaces. Now, lymphangiomas can be classified as being microcystic or macrocystic based on the size of the cyst. And if the cysts are more than 1 centimeter in size, those would be called macrocysts. Smaller than that would be microcysts. So you can have a predominance of each one or a mixture of them. Patients can present with hypertension, ascites, renal insufficiency, hematuria, or a mass. But the imaging findings have been found to be non-specific, and on biopsy, this is a difficult diagnosis to make, especially if you have large cysts. You don't get much material in a biopsy to make a diagnosis, which is why most of them have not been diagnosed preoperatively. On histology, you see dilated lymphatic channels lined by a single layer of endothelial cells, which stain positively with endothelial markers like CD34, CD31, D240 and PROX1 are more specific for lymphatic endothelial cells. Of course, being a malformation, this has an excellent prognosis. So we went ahead and performed immunohistochemistry to distinguish between our differential diagnosis. You can see that Pax8 and cytokeratin are negative, excluding an epithelial tumor. WT1 is positive. And the negativity for Pax8 and cytokeratin excludes cystic Wilms tumor. What we should know is that WT1, the clone that we have, stains endothelial cells, which is why it is positive in this case. If it was positive for Pax8 and WT1, that would be indicative of a Wilms tumor, but Pax8 is negative. And we have positivity for CD31, CD34, and D240, which is positive in these cystic spaces, but the larger vessels which are present here are negative. The leukocyte common antigen highlighted a few lymphocytes that were present in the walls of some of these cystic spaces, and Ki67 staining showed positivity and very occasional nuclei, indicating that this was a low proliferative lesion. So with these features, we made a diagnosis of renal lymphangioma. But the story doesn't end here, and We also found a single subcapsular focus, this is the capsule here, of what appears to be an epithelial proliferation. And this was the only single focus measuring about 1 to 2 millimeters in maximum dimension. You can see here that there are very precise papillary structures, some of which have broad cores with hyalinization, whereas at other places they are forming tubular structures and slender branching papillae. And these are lined by cuboid to columnar appearing cells, which have minimal nuclear pleomorphism, scant cytoplasm, and here you can see some of these cells appear to have a hobnail appearance. What hobnail means is that the nucleus is located away from the basement membrane towards the apical surface. This is a high magnification of the same, showing the same hobnail cells. Some of them had very scant cytoplasm, while others had moderate amount of cytoplasm. So this was a single focus with evident epithelial differentiation because of the presence of papillary structures which had fibrovascular cores, some with hyalinization, hobnail epithelium, but the cytomorphology appeared quite banal with no pleomorphism, no mitosis, no necrosis. So this is the differential diagnosis of renal tumors with papillary architecture. It's an excellent article by Dr. Satish Tikku, who is an alumnus of our department. He did his MD here in 1985, following which he is now a very renowned uropathologist at MSKCC. And I'm not going to go through this because this is mostly covers lesions which are seen in adults. All of these are renal cell carcinomas which show papillary architecture, so I'm not going to discuss this. My differential diagnosis here is simpler. In a child with a papillary architecture, you want to think of TFE rearranged renal cell carcinomas, previously known as XP11 translocation RCC, renal papillary adenoma, metanephric adenoma. Other differentials would be epithelial predominant Wilms tumor. You can get clear cell papillary renal cell tumor or papillary renal cell carcinoma. So these are the entities which you could get in children which have papillary architecture. So let's first look at what would be the most common Wilms tumor again. So the epithelial component shows various stages of differentiation, which includes early tubular forms forming primitive rosette-like structures, and then as they show more differentiation, you have tubular and glomeruloid elements. These tubules, as you see here, are lined by columnar cells with scant cytoplasm, hyperchromatic nuclei, frequent mitosis. So you will see mitosis, nuclear pleomorphism, which was not present in all of our case. So epithelial predominant subtype is defined when more than 66% of cells have epithelial characteristics, and 6 to 9% of Wilms tumors only are epithelial predominant. And it's been found that stage 1 epithelial predominant febrile histology tumors have excellent prognosis irrespective of the age. But we did not have these features in our tumor, so I'm going to exclude it. Coming next to TFE3 rearranged renal cell carcinomas, we know that malignant epithelial tumors are extremely rare in children, and clear cell RCC is very rare except in the absence of a predisposing genetic condition. When you have a predisposing genetic condition, you can get clear cell RCC. Translocation associated RCCs have a greater tendency to affect children than adults, and 40% of pediatric RCC are TFE3 rearranged RCCs. They are defined by translocations involving the TFE3 gene. On histology, you see tubular papillary architecture. You have long, slender papillae which are lined by cells which have abundant clear to pink cytoplasm, well-defined cytoplasmic borders. You have frequent samoma bodies, and they may contain nuclear pigment. Because this has a TFE3 gene rearrangement, it shows positivity for TFE3. We did not have, none of the cells in our tumor showed this abundant cytoplasm, so we're going to exclude this here. Metanephric adenoma is one of the differential diagnoses that Sir mentioned, and metanephric adenoma is the most common epithelial neoplasm to be found in kidneys in children. It is most commonly seen in middle-aged patients, and they usually incidental findings, otherwise they may present with polycythemia, abdominal pain, or mass or hematuria. On microscopy, what we see are small crowded tubules, and papillae are less common. So here you can see a lot of tubules. You may see papillae, and these are lined by small cells with primitive appearing nuclei, and which are quite uniform, which may be similar to the nuclear features seen in our case. Sonoma bodies are common, hemorrhage and necrosis are seen, and they are diffusely positive for WT1. So these features were not present in our case. Moving on to clear cell papillary renal tumor, it's an indolent renal neoplasm composed of low-grade cells described over a wide age range. They are usually small, up to 4 centimeters in size, well circumscribed and encapsulated. And what is a striking feature in these tumors is that the nuclei are arranged towards the luminal aspect as opposed to the basal aspect of the cells, which was seen in some of the cells lining our papillary structures. However, they have a distinctive immunophenotype, that is cup-like staining with CA9. This is what is meant by cup-like staining. It stains the basal aspects, whereas the luminal aspect does not stain. And diffuse CK7 positivity. They are indolent tumors, almost always PT1 with good outcome. Papillary RCC is the second most common type of RCC. It may occur in childhood. Again, you have papillary and tubular structures which have scant to moderate amount of cytoplasm. What is typical is that the pores of the papillae show abundant foamy histiocytes, and Sonoma bodies are very frequent. They show diffuse strong labeling for Amaker. And lastly, papillary adenoma. These are benign uncapsulated tumors of low histological grade, diameter of less than 15 millimeters. They usually clinically silent. They are discovered as incidental findings, mostly in autopsy studies. They are more frequent in elderly patients, and occasional reports are there in children. On histology, they have papillary, tubular papillary architecture, scant cytoplasm, round to ovoid nuclei with minimal nuclear pleomorphism, no nucleoli, rare mitosis. On immunohistochemistry, they are positive for CK7, CD10, and Amaker. And so we went ahead and did the immunohistochemistry. You can see that CK7 is positive, as would be in most of the papillary lesions. PAX8 is positive, indicating that it is a renal epithelial origin tumor. WT1 was negative, which excludes the possibility of an epithelial predominant Wilms tumor or a metanephric adenoma. TFE3 was negative, excluding TFE3 rearranged RCC. Amaker was negative, excluding papillary RCC, and cup-like staining for CA9 was not seen, excluding clear cell papillary renal cell tumor. So with this, we made the final diagnosis of renal lymphangioma with incidental papillary adenoma. Now, benign vascular tumors and malformations are a group of common as well as rare disorders of blood vessel growth which lead to identifiable vascular lesions and their associated deformities. Previously, the term hemangioma was used by pathologists to broadly describe any benign non-reactive vascular process with an increase in normal or abnormal appearing vessels, and then they would subclassify based on the predominant type of vessel. This was a simple and convenient approach for the pathologist who was often not apprised of the clinical or radiographic findings, and it conveyed a limited amount of biological information to the clinician. So clearly it did not work. The advances in understanding the pathogenesis of this diverse group of lesions led to a shift in the nomenclature with a multidisciplinary consensus, and the ISSVA, or International Society for Study of Vascular Anomalies, was officially founded in 1992, and they presented a classification system which was adopted in 1996, and in 2014 they updated it by incorporating genetic characteristics along with the histopathological features. So what they basically did is they divided benign vascular lesions into two groups, tumors and malformations. So tumors or hemangiomas are lesions that arise due to actual cellular proliferation, that is, they are true neoplasms, whereas vascular malformations are developmental abnormalities of embryonic vasculature, and then these are further classified, with vascular malformations being classified based on the type of vessel they arise from, and you can get combined vascular malformations. So while tumors grow in a disproportionately rapid manner relative to the patient and they may undergo involution, they composed of capillary-side vessels. On the other hand, vascular malformations, they are typically evident at birth. They grow proportionately with the patient. They do not show proliferative activity and they do not show regression. They may be composed of arterial, venous, capillary or lymphatic channels, or alone or in combination, and they may be associated with specific genetic defects. Histological distinction between them is not always possible without clinical and imaging information, and secondary factors can complicate or blur the distinction between the two. Vascular malformations, they do not regress, proportional growth is usual, but occasionally they can show disproportionate growth. Thrombosis, vascular ectasia, and an increasing accumulation of fluid can give the impression of more rapid growth, which might cause confusion in the diagnosis. Further, deeply situated malformations may not become evident until well after infancy or childhood, making the age at detection occasionally unreliable. Lymphatic malformations, previously referred to as lymphangiomas, are abnormalities of morphogenesis rather than a neoplasm, and the term lymphatic malformation is preferred. So it refers to a benign vascular lesion composed of a localized collection of dilated lymphatic channels. They're thin-walled structures lined by a single discontinuous layer of flattened endothelial cells, as we saw in our case. They express vascular markers like CD31, ERG, and lymphatic specific markers like protoplanar or D240, LYV1, and PROX1. Recently, PIK3CA mutations have been described in about 75% of lymphatic malformations. You can see that they are classified as common malformations, macro, microcystic, and mixed, and they may be seen in association with a number of syndromes. They may also be present in combinations such as capillary lymphatic, venous lymphatic malformation. These are an extremely unusual cause of a renal mass, first described in 1950s, but till today the current disease understanding is based only on a few case reports in series. They are caused by an inability of the renal lymphatic system to communicate with the normal lymphatic system, resulting in lymphatic dilatation and formation of a single or multilocular cystic mass. They may present with abdominal pain, lower back pain, hypertension, hematuria, palpable mass, proteinuria, edema, or others. Approximately 2/3 of these have been found to be bilateral. The rate of misdiagnosis is very high because they cannot be accurately diagnosed by imaging and also due to lack of awareness of the disease. Lee et al. Recently reviewed all the cases of renal lymphangioma and lymphangiectasis in literature, and they created a pattern map based on the imaging finding, classifying these as perinephric, peripelvic, perinephric plus peripelvic types, and special type 1 and special type 2. And they found that these special types tended to occur more frequently in childhood. What is to be noted is that 5 to 15% of renal malignant tumors will have multilocular cystic changes. In most cases, clinical history, biochemical indicators, and imaging findings can help to differentiate these from lymphangiomas. Some with complex atypical multilocular cystic structures may be difficult to distinguish from malignant tumors, and in some, accurate diagnosis requires biopsy or only on post-operative histological examination that they can be diagnosed. Majority of the cases have been diagnosed as malignancy and have been treated with nephrectomy. Occasional reports have shown that the lymphangiectasia or lymphangioma in the other kidney, when present, will increase in size in a short period after removal of the first kidney. And partial natural improvement has also been reporting, suggesting that the disease may be self-limited. The description of PIK3CA mutations has raised the possibility of targeted therapy in these patients, especially those which have syndromic associations. So this study recently performed targeted next-gen sequencing in 30 cases of lymphatic malformations to define the spectrum of genomic alterations, and majority of the patients they included were pediatric patients with a slight female predominance. 23% had overgrowth syndromes, and they found that PIK3CA mutations were seen in 67%, NRAS mutations were seen in 17%, mostly in those with Kaposiform histology. They've also noted that the variant allele frequencies were relatively low with a median of 6%. They also described an index case who had a large retroperitoneal lymphatic malformation, which on CT appeared to be possibly neoplastic. They did a core biopsy, it was non-diagnostic. Then they went ahead for an open biopsy to get tissue for to molecular testing, exactly as Sir mentioned. And they found on next-gen sequencing that there was a PIK3CA gain-of-function mutation, and they deferred surgery because the extent of the tumor, it was a large retroperitoneal mass going into the pancreas as well. And they did a personalized clinical trial of the PIK3K alpha inhibitor alpelisib. and they found that at 1 year, the patient achieved complete radiological response. Interestingly, they continued the drug for 2 years and then they stopped it. Once they stopped the drug, there was again an increase in size of the tumor. And then they continued till 3 years of age. We also performed PIK3CA mutation testing in our case, and we performed it using a real-time PCR technique. We did not identify the mutation, and previously all the reports have performed next-gen sequencing. So it is possible either that this patient does not have this mutation, or that because of the low variant allele frequency, it is not detected by this technique, whereas next-gen sequencing is much more sensitive. Coming to renal papillary adenomas, these are clinically silent tumors. They're mostly seen in adults. In elderly patients, long-term hemodialysis, renal glomerulosclerosis, acquired cystic disease, undergoing transplantation for end-stage renal disease, and in kidneys with RCC. So it has been postulated that maybe these are reactive proliferations in response to these, but some of them have shown genetic alterations, and they are considered, some of them are considered to be precursors to renal papillary adenoma. However, they have excellent prognosis, virtually no metastatic potential. Earlier, the cutoff for these tumors was 5 millimeters, but then the recent WHO said that up to 15 millimeters can be classified as a papillary adenoma, because tumors which are up to 15 millimeters in size have no metastatic potential. And one of the largest autopsy series to examine kidneys for papillary adenomas, they looked at 402 autopsies. Each kidney was sectioned at 1 to 2 millimeter intervals, which is very extensive. And they included patients from newborn to 92 years. They found that papillary adenomas range from 0.5 to 5 millimeters in size, and they divided them into 4 groups: type A, B, C, and D, and mixed types, which are seen here. So type A had slender papillae, small cells with scant cytoplasm, while type B had broad papillae with hyalinized pores and small cuboidal cells. So we saw both these kinds of areas in our tumor. So ours is probably a mixed type A, type B. So to conclude, renal lymphatic malformations are extremely rare, especially in children. Clinical and imaging findings may mimic more common renal masses, and histological examination with immunohistochemistry is necessary for diagnosis. The presence of PIK3 mutations, PIK3CA mutations in these tumors has opened up avenues for targeted therapy, especially in syndromic cases. Renal papillary adenomas are another rare tumor in the pediatric age group, often incidentally detected, has not been described previously in association with vascular malformation. On histology, they may raise concern for malignancy, but using immunohistochemistry, we can easily distinguish them from morphologically similar lesions. I'd like to thank Dr. Sandeep Mathur for doing the PIK3 mutation analysis in this case. If there are any questions.
Thank you, Dr. Aanchal. So, just a couple of questions I want to ask. In CT, there was no cystic traces that was seen, and in macroscopy, I think we were not able to see any cystic traces. To our understanding, it is a clinician that there are no cystic traces, so we don't even consider cystic nephropathy or CPDN or cystic twins. So, because we've done extensive article literature, so are there any reports of cystic nephropathy reported with an absence of macroscopic cystic traces on imaging or gross?
Cystic nephroma.
Yeah, because it appears as a bleeding or examination.
No, those cystic nephroma would definitely show cystic appearance on gross. It would not appear solid on gross examination. I only kept them in my differential diagnosis because just for residents to know that when you're seeing cystic lesions in the pediatric kidney, that you should think of these. You would definitely see cysts in gross.
Secondly, regarding the same aspect, because we reviewed the literature on the renal lymphatic malformation. So, did some of the patients from that group also had similar picture in which there was no cystic traces seen on the imaging?
So, most of them underwent nephrectomy because they could not be diagnosed as a lymphatic malformation preoperatively on imaging or even on biopsy. Majority of them were diagnosed as malignancy.
What was the prevalence in that cadaver study on the of the AIIMS? It was 402
Yes.
cadavers. The prevalence in the whole sample.
Yes, I think I haven't mentioned it here, but I think they found it in 5% of cases.
And sir, lastly, just as a practice change, do you think that we were early ready FAC done when we were studying here and it was done the same way, we got the report the same way? And I think rather than missing your diagnosis, we were very fortunate to pick some CCSP patients early on, which could be started on chemotherapy. We know that conversion is intensified in such patients. So and we are only one of the few centers who could diagnose this on FAC. So should we again go back to that practice, sir?
The answer is more complex. Our aim is not to return to the old days, but to see whether we can do the kind of molecular testing which is required in many of the cases in the tissue that is sampled. And there is no doubt that biopsies are FNAC for doing molecular testing. We have done a number of studies on molecular testing on FNAC. And invariably, the quality of DNA which comes out varies from case to case. So if you get a good sample, everything works. If you don't get that good a sample, and it is so operator dependent, that goes down. So my answer would be that definitely a FNAC does not harm the patient. If the mass is abating on the anterior abdominal wall, you should do an FNAC. Unguided. The moment you are in a situation where you say we will do it under ultrasound guidance, you will mostly die. The operator is not going to get good mass, good material because the mass is small. So he's going to put a long needle, lot of blood will come out, will mix with the tumor, it will not be suboptimal. But now that the new center has been set up in the MCD, and new systems are being evolved, definitely we must have a relook and try to do more cell blocks, more core biopsies, and more clinico-pathological correlation, especially with radiology, on a one-on-one basis, so that we are giving a more personalized approach. So, for example, in this case, if we had put the needle of FNAC, got blood or some fluid, and we don't have a diagnosis. We have done a core biopsy in this. We possibly could have diagnosed, but probably would have missed. I don't know. Probably very answer could have made it, but we might have missed. But if we had molecular testing as a routine and we do a next-gen sequencing of every case of bills which comes, we should. Then we would have found the FPC mutation and we could have given us the idea that this is going to come. So we should move towards molecular. And for that, I think we should start with maybe biopsies of FPC. As a routine, we should do it for every patient. Upstaging is an issue that I will have to, because generally the tendency is to feel FNAC doesn't upstage, so needle biopsy. How true that is, I don't know, but my own experience is FNAC doesn't. The poor needle generally will give some feedback, and that would affect something like an acquired tumor. Acquired tumor is the only chance is you remove it and complete resection and patient is cured. Otherwise, it will come. So it's a small stage, but then what are the chances that it will be a high, low stage rapid tumor? That's the less. So I think let us sit together and develop a consensus and start practicing molecular pathology. So, before I comment, I would like to also add to what the said. We have seen a lot of, there were in our department a lot of experience with FNAs on being a pediatric. So, even when I was a senior resident, almost all the cases were but we have the case for the
sir rightly said, what tumors in the setting where we are going to give NACT, you will give chemotherapy, there it does make sense, you know, to have some sort of tissue available. Like same experience I had for breast or breast cancer. Most of our cases, almost 60% of our cases, they undergo NACT. So they don't have any tissue when many times remaining after the NACT. It does make sense to have a pre-NACT tissue sample. If you have a more unique seed coming up and you need to go back and do something. In that point of view, in a setup like ours, it does make sense to increase amount of risk taken from the patient's point of view. That is something worth pursuing. And in FNAC, we can have cell blocks which will extend material. Most of your tumors, pediatric tumors, are very cellular. Great amount of heat. So we can have these cell blocks made of tissue, frozen and kept from the FNA passes as a not a glimpse. That is something that pediatric group can work out and know. It is something very good. About the my distinct comment was about the gross in this case. You know, from the microscopy, what it shows, if you go back to the gross, it could have been a kind of spongy appearance cut section. If you go back to the specimen and see, because such kind of a fluid cystic spaces, which typically be spongy, because as then they lose out fluid, and that would be the differentiating features of other solid tumors in this age group which you get. That was a
Yes. We didn't go back and look at it, sir, but yes, you can see that there are some kind of spaces which are discernible.
Macroscopically looking like a multicystic what was the last thing. What I felt about it now is, especially the fresh state of the it could be very spongy, you know, it could be filled with fluid, yes.
And it also has a glistening surface. The cut surface is glistening, which would indicate that there is some fluid within. There is. Yeah. That's right.
I think in such a situation, probably it's very difficult to make any of the time. Radiology also and clinical also. So in this particular situation, with the idea to do it. So whatever your features on table when you change that is important. Otherwise, it's not possible to take the classical it's difficult to under an effect is and 100% effect out of 100 it's like 1 or 2 cases will be like this. Rest of them would be so incidence of such occurrences would be less. So it's really not really change the paper.
The tumor was localized to one core, and then I think, as I said earlier, we are planning the process of planning to do the passing of the case of each tumor. Specific cases where there is no node involved. So in this case, because the tumor is localized to one core, not anything, and they easily separate the pelvis from the mass. That's why I plan easily to pass it. And if other things come, we will again go and they will be kidney nodes, lymph nodes will become lost. That's why I go for the passing.
So one should always be very prepared that it's to pass it effectively. With the idea that one has to go back and convert it to that.
Yes.
So biopsy can do that biopsy and find PGI may could not be past years. But I think that led to increase in staging of the tumor and some local evidences are also there. So that is why now they have gone back and relying more on clinical and
Yeah, so actually we also ultrasound guidance only in cases where there is a lot of solid and cystic area. So we want to go to the solid area, and that is where we want the ultrasound or ECG lesions. So superficial lesions, as Dr. mentioned, avoiding the family one or the posterior is easy to avoid CMV. And the best part was that this morning that the answer that it is, but legally, if you go legally, nowadays all the protocols, it is not required to have a histological diagnosis or a cytological diagnosis before you leave the room. Knowing very well that we sometimes will not.
Yeah, so if we look at,
Actually, regarding the glacial development, so David said actually that the institute that there is this rose and cell block also in the unsold state as well. So we were getting the cell block there also. And at that time only we didn't get an idea that
we need to focus on that, but if I could just elaborate on what you just said, the issue of upstaging does not really, if the tumor is already affecting on anterior abdominal wall, it's already late stage. The issue is more for tumors which cannot be cured by chemotherapy. So if a Wilms tumor is upstage, you are anyway going to give, there will be some smell, will anyway be giving treatment, and there is excellent treatment available. The problem comes with the renal cell carcinoma or with an adenoid tumor which don't have good chemotherapy available. But if you look at the sea of criteria for biopsy, it is these cases where they want the biopsy to be done because the diagnosis needs to be established. And probably we should do the biopsy so that an early diagnosis is made. Technically, if you look at it, for example, pancreas, they went with ultrasound guided aspiration for pancreas using EUS because they didn't want tumor to come. Same with gallbladder. These are very aggressive tumors. Both RCC and rhabdoid are aggressive tumors. In there, the tumor still can be. So if it is operable, and there is a chance it could be these two tumors like AIIMS, we should operate. But I think it's every case requires careful evaluation.
For creating human mind. So it will help us for region and also create a rank for other human mind. So I think that is the way that we need to have human mind for molecular, because now more and more personalized medicine is coming. So according to the molecular changes, special drugs, the whole Wilms tumor treatment will be changed. So in the next 5 years, we see that every patient needs to be categorized and get some other chemotherapy for that. Something
one point this will also guide for the liquid biopsy because the passage was from line to the experience of RCC, where the RCC swings are
I think amazing case, Aanchal.
The discussion after this is extremely valuable about the management of pediatric renal tumors and what is the way forward. Thank you, everyone. Thank you, sir, for